Today, the world is once again facing concerns over an Ebola outbreak in Central Africa. Recently, outbreaks linked to the rare Bundibugyo strain of the Ebola virus have been reported in the Democratic Republic of the Congo and Uganda. According to recent reports, more than 300 suspected cases and over 80 deaths have already been reported, leading the World Health Organization to declare the situation a global public health emergency. However, this is not the first time the world has faced Ebola. In fact, since its discovery, more than 25 Ebola outbreaks have occurred, mainly in Central and East Africa. The first outbreak occurred in 1976 in two simultaneous regions of Africa. One outbreak was caused by the Sudan virus in Nizara in present-day South Sudan, while the second outbreak occurred in Yambuku in present-day Democratic Republic of the Congo near the Ebola River, from which the disease got its name. Among all outbreaks, the largest and deadliest Ebola epidemic occurred between 2013 and 2016 in West Africa, mainly affecting Guinea, Liberia, and Sierra Leone. During this devastating outbreak, more than 28,000 cases and over 11,000 deaths were reported, overwhelming healthcare systems and causing global panic. Ebola virus belongs to the Filoviridae family and the Ortho-Ebola virus genus. Currently, 6 species of Ortho-Ebola viruses have been identified, among which the major disease-causing strains include Ebola virus, Zaire strain, Sudan virus, and Bundibugyo virus. Among these, the Zaire strain is considered the most deadly and was responsible for the massive West African outbreak. Currently, there are 2 WHO pre-qualified vaccines available for prevention of Ebola virus disease caused specifically by the Zaire Ebola virus strain. The first vaccine is Ervebo, which is given as a single-dose vaccine and is currently the main vaccine used during active outbreak situations. The second vaccine regimen consists of Zabdeno followed by Mvabea, which are administered as a 2-dose schedule to provide longer-term protection against the Zaire strain of Ebola virus. However, it is important to understand that these vaccines are specifically designed for the Zaire Ebola virus strain and do not provide confirmed protection against other Ebola strains such as the Sudan or Bundibugyo strains. The virus is zoonotic, meaning it naturally resides in animals and occasionally spills over to humans. Fruit bats are considered the primary natural hosts, while other animals such as apes, monkeys, and forest antelopes can become infected and serve as intermediate hosts. Humans can contract the virus through direct contact with the blood, secretions, organs, or other bodily fluids of infected animals, often during hunting, butchering, or consumption of bushmeat. Now, human-to-human transmission of Ebola virus disease mainly occurs through direct contact with infected body fluids such as blood, saliva, urine, feces, sweat, breast milk, semen, and other secretions. In addition, transmission can also occur through contact with contaminated objects like bedding, clothes, needles, or medical equipment used by infected patients. The virus usually enters the body through mucosal surfaces such as the eyes, nose, or mouth, and sometimes through cuts or broken skin. Importantly, Ebola virus can persist in certain body fluids for prolonged periods even after recovery. For example, the virus has been detected in semen for several weeks to months after the initial illness, and therefore, sexual transmission from recovered patients has also been reported. In addition, transmission from infected pregnant mothers to their fetuses can also occur. Furthermore, because the exact survival time of the virus outside the human body is uncertain, materials used by infected patients are usually burned or disposed of as medical waste to prevent further spread of infection. Another important factor contributing to transmission is traditional funeral practices in some affected regions, where family members may directly touch or wash the bodies of deceased individuals. Since the bodies of infected patients contain high viral loads, such close contact during funerals can significantly increase the risk of transmission and further spread of the outbreak. Ebola virus is a filament-shaped enveloped virus that contains a negative sense RNA genome, and importantly, this genome encodes several proteins that help the virus survive and replicate inside the host. First of all, the virus produces nucleoprotein, glycoprotein, RNA-dependent RNA polymerase or L protein, and four structural proteins known as VP24, VP30, VP35, and VP40. Now, as we move from inside out of the virus, we first see the RNA genome, which acts as the genetic blueprint of Ebola virus. Surrounding this RNA genome, we then find the nucleocapsid. And importantly, this nucleocapsid is mainly formed by nucleoproteins that tightly wrap around and protect the viral RNA. In addition, attached to this nucleocapsid are proteins such as VP35 and RNA-dependent RNA polymerase protein, which together form the active polymerase complex responsible for viral replication and transcription. VP30 is also associated with the nucleocapsid and plays an important role in Ebola virus replication. In addition, VP30 also helps assemble and package the viral RNA into the nucleocapsid, forming the inner core of the virus. Moving further outward, we next encounter VP24 and VP40, which are matrix proteins located beneath the viral envelope. Together, they help maintain the structural stability and shape of the Ebola virus, while also playing an important role in assembly, budding, and release of new viral particles from infected cells. Finally, on the outermost surface, the virus is covered by a lipid envelope derived from the host cell membrane, and projecting from this envelope are the glycoprotein spikes. These GP spikes are extremely important because they are the structures that attach to host cells and mediate viral entry. Therefore, if we move from the innermost part of the Ebola virus toward the outside, we first encounter the RNA genome. Surrounding this RNA is the nucleocapsid, mainly formed by nucleoproteins along with VP35, VP30, and the L protein, all of which help in replication and transcription. Outside the nucleocapsid, there are the matrix proteins VP24 and VP40, which provide structural support and help in viral assembly and budding. Further outward, the virus is enclosed by a lipid envelope. And finally, on the outermost surface, GP spikes project outward and help the virus attach to and enter host cells. After understanding the structure of Ebola virus, it is also important to understand how the virus infects and disrupts the body's immune system. Human infection with filoviruses usually begins when contaminated body fluids come into direct contact with broken skin or mucosal surfaces. Once inside the body, the Ebola virus mainly targets monocytes, macrophages, and dendritic cells, which normally act as the body's first line of defense against infections. However, instead of destroying the virus, these immune cells themselves become infected and help spread the virus throughout the body. After enters the body, the glycoprotein spikes present on the surface of the virus help it attach to host cells like macrophages or monocytes. The glycoprotein spikes on the surface of the filovirus act like keys that help the virus unlock and enter human cells. First, when the virus comes close to a host cell, These spikes attach to certain molecules present on the cell surface. These surface molecules help the virus stick to the cell and get pulled inside through a process called endocytosis, where the cell essentially engulfs the virus into a small vesicle. These small vesicles, also known as endosome. Now, an important point to understand here is that the membrane of this endosome contains a special intracellular protein called NPC1 or Niemann-Pick-C1, which normally functions as a cholesterol transporter. However, Ebola virus uses this NPC1 protein as its essential receptor for entry into the cell cytoplasm. So, after entering the endosome, the viral glycoprotein spike protein is processed by host enzymes called cathepsins. In other words, these enzymes partially cut and modify the spike protein. As a result, a previously hidden binding site on the viral GP protein becomes exposed. Consequently, the processed glycoproteins can now bind effectively to the NPC1 receptor present on the endosomal membrane. This interaction is extremely important because it triggers fusion of the viral envelope with the endosomal membrane, thereby allowing the viral RNA to escape into the cytoplasm where replication begins. Once the viral genome enters the host cell cytoplasm, like most viruses do after entering a host cell, the Ebola virus hijacks the host cell machinery to replicate itself. First, the virus produces viral proteins and copies of its RNA genome required for survival and multiplication. Then, these newly formed viral components are assembled into new viral particles inside the host cell. Finally, the newly formed virions bud from the host cell membrane and get released, allowing the infection to spread to neighboring cells. After this rapid viral replication infects monocytes and macrophages, begin releasing a massive amount of inflammatory mediators such as cytokines, chemokines, nitric oxide, and reactive oxygen species. Consequently, this excessive immune activation leads to a cytokine storm, which plays a major role in the severe manifestations of Ebola virus disease. At the same time, Ebola virus also actively disables the body's innate antiviral defense mechanisms. Normally, when a virus infects a cell, host intracellular sensors detect viral RNA and trigger interferon production, especially type 1 interferons, mainly interferon alpha and interferon beta, which act as important antiviral signaling molecules. These interferons warn neighboring cells about the infection and activate antiviral proteins that help limit viral replication. In addition, they stimulate natural killer cells, macrophages, and other components of the immune system to destroy infected cells. However, Ebola viral proteins, especially VP35, prevent activation of these interferon signaling pathways by blocking the host cell's ability to recognize viral RNA. As a result, infected cells fail to produce adequate interferon responses during the early stages of infection. Consequently, the virus replicates rapidly, spreads extensively throughout the body. Moreover, even if some interferons are still produced by the host cells, the Ebola virus further suppresses the antiviral response through its VP24 protein. Normally, these interferons activate STAT1 proteins, which then move into the nucleus and switch on antiviral genes responsible for producing interferon-stimulated antiviral proteins. However, VP24 prevents STAT1 from entering the nucleus, thereby stopping the expression of these antiviral proteins. Consequently, neighboring cells fail to establish an effective antiviral state, allowing the virus to continue replicating and disseminating unchecked throughout the body. Meanwhile, in dendritic cells, the Ebola virus causes a different but equally dangerous effect. Normally, dendritic cells act as important antigen-presenting cells. When a virus enters the body, these cells capture viral antigens, process them, and present them to T lymphocytes through MHC molecules, thereby activating T cells and initiating the adaptive immune response. Consequently, this helps the body develop a targeted immune response against the infection. However, when dendritic cells become infected with the Ebola virus, they fail to mature and function properly. In addition, the expression of MHC class II molecules becomes suppressed, leading to defective antigen presentation to T lymphocytes. Therefore, lymphocytes do not receive the necessary survival and activation signals required for an effective adaptive immune response. As a result, many lymphocytes become functionally inactive or undergo apoptosis. As a result, the body fails to generate an adequate virus-specific immune response during the early stages of infection, thereby allowing uncontrolled viral replication and widespread dissemination throughout the body. Thus, through excessive inflammation, suppression of interferon responses, impaired dendritic cell function, and lymphocyte death, Ebola virus causes profound dysregulation of the immune system, which ultimately contributes to severe disease, multi-organ failure, and death. In addition, there is massive destruction of lymphoid tissues such as lymph nodes, spleen, and thymus, leading to severe lymphocyte depletion and lymphopenia. As a result, patients become immunosuppressed and may also become highly susceptible to secondary bacterial and fungal infections. At the same time, these infected immune cells carry the virus through the bloodstream and lymphatic system, allowing widespread dissemination of the virus to multiple organs, including the liver, spleen, adrenal glands, and endothelial cells lining blood vessels. In some cells, especially hepatocytes, the infection becomes cytolytic, meaning it directly destroys the cells. Therefore, liver damage occurs, leading to elevated liver enzymes and impaired production of clotting factors, which further contributes to coagulopathy. Along with liver damage, disseminated intravascular coagulation further severely disturbs the normal clotting mechanism of the body. Normally, the coagulation system remains carefully balanced and forms clots only when required, such as during injury. However, in Ebola virus disease, massive cytokine release, endothelial injury, and activation of tissue factor abnormally trigger the coagulation cascade throughout the body. As a result, widespread formation of tiny fibrin clots begins inside small blood vessels. However, because this coagulation process continues uncontrollably, platelets and clotting factors start getting consumed rapidly, often faster than the body can replace them. At the same time, the liver, which normally synthesizes most clotting factors, is itself damaged by the viral infection. Therefore, the liver cannot adequately produce new clotting factors to compensate for those being lost. Consequently, patients develop thrombocytopenia along with severe depletion of important clotting factors. Therefore, the body paradoxically enters a dangerous state where both excessive clot formation and bleeding occur simultaneously. First, the tiny fibrin clots formed inside small blood vessels, known as microvascular thrombi, obstruct normal blood flow. Consequently, oxygen supply to tissues decreases, leading to tissue ischemia, cellular necrosis, and organ damage involving organs such as the kidneys, liver, spleen, and gonads. In addition, direct injury of endothelial cells by the Ebola virus, together with the massive release of inflammatory cytokines, damages blood vessels and increases vascular permeability, allowing fluid and blood components to leak into surrounding tissues. Consequently, patients may develop hemorrhagic manifestations such as petechia, ecchymosis, mucosal bleeding, and bleeding into internal organs and skin. However, despite these hemorrhagic signs, massive blood loss is actually uncommon in most patients, except in situations such as childbirth where severe bleeding may occur. At the same time, inflammatory cytokines, nitric oxide, and endothelial injury further increase vascular permeability. Therefore, large amounts of fluid leak from blood vessels into surrounding tissues, producing edema, hypovolemia, septic shock, and circulatory collapse. Nevertheless, despite these severe pathogenic effects, some patients are still able to mount an effective filovirus-specific adaptive immune response. In survivors, this immune response gradually controls viral replication, clears viremia, and leads to clinical recovery. However, recovery is often slow and incomplete, especially in patients who develop severe organ dysfunction or long-term complications. Now, the clinical manifestations. After the virus enters the body, it undergoes an incubation period that usually ranges from 2 to 25 days, most commonly around 6 to 10 days. During this incubation phase, the patient remains asymptomatic and non-contagious. However, once symptoms begin, the disease usually starts suddenly with a non-specific flu-like illness characterized by high fever, chills, severe headache, myalgia, fatigue, sore throat, cough, and pain in large joints. In many patients, a maculopapular rash may also develop. As we saw in the pathophysiology, Ebola virus does not remain confined to a single organ. Instead, it spreads throughout the body and damages multiple organ systems. Therefore, after about 5 to 7 days of illness, patients typically enter a second and much more severe phase of the disease. During this stage, the gastrointestinal tract becomes severely affected, resulting in nausea, vomiting, diarrhea, and abdominal pain. Simultaneously, respiratory symptoms such as chest pain and cough may appear, while involvement of the vascular system can lead to postural hypotension and edema. Furthermore, central nervous system manifestations, including confusion, severe headache, altered mental status, and even coma, may develop in critically ill patients. Meanwhile, hemorrhagic manifestations may also appear due to severe coagulopathy and endothelial dysfunction. Common bleeding manifestations include subconjunctival hemorrhage, petechial rash, gingival bleeding, and bleeding from injection sites. Less commonly, patients may develop epistaxis, hematemesis, hematuria, or melena. In severe cases, patients may rapidly deteriorate and die within 4 to 14 days due to multi-organ failure, shock, acute renal failure, or respiratory failure. This mainly results from widespread viral infection, cytokine storm, vascular leakage, and DIC, which together cause severe tissue damage and reduced blood supply to vital organs. Diagnosing Ebola virus disease based on symptoms alone can be challenging because its early clinical features closely resemble several other tropical infections, such as malaria, typhoid fever, septicemia, viral hepatitis, leptospirosis, yellow fever, and Lassa fever. Therefore, whenever a patient presents with a compatible clinical picture, especially in the setting of a known outbreak or a history of exposure to infected individuals, bats, bushmeat, or affected regions, Ebola infection should be strongly suspected. However, definitive diagnosis requires laboratory confirmation. The current gold standard diagnostic test is reverse transcription polymerase chain reaction, which detects Ebola viral RNA in blood samples and is most useful during the acute phase of infection. In addition, antigen detection tests can identify viral proteins and may provide rapid diagnosis during outbreaks. Furthermore, ELISA-based antibody tests, including IgM and IgG detection, can be used during the later stages of disease and in recovered patients to identify an immune response against the virus. Because Ebola is a highly hazardous pathogen, all specimen collection and handling must be performed using strict biosafety precautions and appropriate personal protective equipment. In addition, because Ebola virus affects multiple organs throughout the body, laboratory investigations often reveal widespread systemic involvement. Common findings include leukopenia, followed by leukocytosis, as the inflammatory response intensifies. And also, marked thrombocytopenia is frequently observed due to increased platelet consumption during DIC. And furthermore, elevated liver enzymes, particularly AST, more than ALT, indicating liver injury. Kidney involvement may lead to increased creatinine and urea levels with proteinuria. Furthermore, electrolyte disturbances such as hyponatremia, hypocalcemia, and potassium abnormalities are frequently observed. Coagulation studies often show prolonged clotting times, reflecting coagulopathy, while inflammatory markers such as C-reactive protein are typically elevated in severely ill patients. Once the diagnosis of Ebola virus disease is confirmed or strongly suspected, treatment should be provided by trained healthcare workers using appropriate personal protective equipment to prevent further transmission. Historically, management of Ebola was mainly supportive because no specific antiviral therapies were available. However, major advances during recent outbreaks led to the development of effective monoclonal antibody therapies. Currently, Ansuvimab and Regn-EB3 are approved treatments for Ebola virus disease caused by the Zaire strain and should be administered as early as possible after diagnosis to improve survival.